Thank you everyone for taking the time during the summer to join this workshop. I know people's schedules get kind of crazy, but we had lots of good interest, so we're really pleased to see that and excited. So maybe I will just kick us off and then we can get into our content. So thanks everyone for joining. My name is Shelley Vanderhout. We'll do a really quick round of intros for our presenters on the next slide, but welcome to the Patient, Caregiver, and Provider Co-Design workshop in the Health System Impact Training Platform. All right, so as I mentioned, my name is Shelley Vanderhout. I'm originally trained as a registered dietitian, and now I'm a learning health system scientist at the Institute for Better Health at Trillium Health Partners in Mississauga, Ontario. I'm also a Health System Impact Fellowship alum. I did a postdoc fellowship at the University of Ottawa and the Children's Hospital of Eastern Ontario. So I'm very familiar with the program, and now I am a co-lead on sort of the national group that leads this program. And my role is co-leading the mentorship stream. And as part of that, I support delivering some of the curriculum, for example, this workshop that we're at today. Now I'll hand it over to my co-presenters to introduce themselves. So Bhavni.
Thanks, Shelley. Hi, everyone. Good afternoon. My name is Bhavni, and I was a working caregiver for 6 years for my dad, who was diagnosed with dementia. And as his needs increased, I realized that we needed some more support. So I became a full-time caregiver to him as we cared for him at home until he passed. And to become a full-time caregiver, I stepped away from the corporate side of life, where I have an operations strategy and change management background, and to give me some flexibility, sort of moved into the consulting space. At the Institute of Better Health, we have a caregiver advisory board where I co-chair that. At Alzheimer's Society Peel, I'm on their advisory panel. And at the Interprofessional Education Department at U of T, I sit on their advisory and governance committee, and I'm happy to be here today to present my point of view and collaborate with everyone. Danny.
Thanks, Bhavni. Hi, everybody. I'm Danny Jacobson. It's really great to be here today. I have my PhD in public health from U of T, as well as a women's health collaborative specialization, and went on to do my postdoctoral fellowship at Women's College Hospital. And overall, my research spans quite a few substantive areas, but the overall umbrella is on patient care experience research and how patients navigate through the healthcare system. So really looking forward to being able to be here with you today. I also have a little bit of my own informal caregiving experience, and all these things kind of merge together, where like the number one thing I'm interested in is just helping to improve healthcare system operations.
Wonderful. Thanks so much, Bhavni and Danny. Okay, so before we get started, I'll just give you a snapshot of the agenda for the next hour and a half or so. So we'll start off with 30 minutes of a primer on what co-design is, and we'll give you a little sampling of some of the commonly used methods in healthcare co-design. Then we have 40 minutes of breakout groups. So you'll notice there's some wonderful facilitators on camera here. Sorry that we don't quite have enough time to do a full round of intros, but you'll get to meet at least one of them in your breakout groups that you'll be automatically assigned to. And so in those groups, you'll do a quick co-design case study, trying out some of those commonly used methods that we go over in the slides. And then for the final 20 minutes, we'll have just a quick report back, reflection, and Q&A time period. And this workshop really is meant to be quite informal, so please make full use of the chat, ask any questions that you might have, as we're presenting, and we'd love to hear your comments and feedback. So feel free to just use that. And if you do have questions throughout, please ideally save them for the end, but if there's something really pressing, then you can raise your hand and we'll do our best to respond. And another thing before we get started, just recognizing that we are joining from across the country, I wanted to acknowledge that we're gathered today on lands that have been inhabited by Indigenous peoples since time immemorial. From coast to coast to coast, we recognize the ancestral and unceded territories of the First Nations, Inuit, and Métis people who've cared for these lands for generations. And if you'd like to put a specific land acknowledgement relevant to where you're joining from today in the chat, please feel free to do so. So just to give a bit of context for where this workshop is kind of coming from, of course, this is under the umbrella of the curriculum provided by the Health System Impact Training Platform. And some of you may have remembered back in January of this year, we provided a workshop already about evaluation. And of course, here we are today focusing on patient, caregiver, and provider co-design. And this is all kind of under this framework of learning health systems, which you may be familiar with from some of the other sort of themes and materials, resources, and curriculum that comes out with this program. The Health System Impact Training Platform is very aligned with the concept of a learning health system. And if you're not sure what a learning health system is, this framework shown on this screen was developed by some of my colleagues at the Institute for Better Health. It really just represents, as you can see, gears working together to drive continuous learning and improvement forward. So we think of it as having 5 different components that you can see here. They don't necessarily work in a specific order always, but the idea is to sort of gather insights and data from at the population level to understand what needs improvement, gather some existing evidence and current knowledge on that specific topic of improvement, then bring in patient, caregiver, and provider partners to help co-design a solution or a new innovation, implement it in the health system setting, and then evaluate and continuously and iteratively work through this cycle sort of again and again to drive improvement forward. And so you can scan this QR code here if you want to read more. And you can also keep your eye out for future workshops coming on the remaining 3 topics shown here. So for today, our learning objectives are first to describe what co-design is, what it's used for, and why it matters. Then identify key considerations when patient, caregiver, and provider partners are engaged in co-design activities. And then finally, apply and reflect on different co-design approaches to an example health system problem. Okay, so first off, what is co-design? So we think of it as a process for developing solutions to complex problems in healthcare for our setting. And co-design privileges lived expertise and lived experience by actively involving people who are directly affected by an issue or, an illness, or who work in the health system as expert collaborators. And this includes patients, caregivers, and providers. And it really represents a shift from consulting people and just kind of asking their opinion in a one-directional way to empowered involvement and decision-making. So really true collaboration by creating space for dialogue and really seeking to genuinely understand one another's perspectives. And so we can look to the literature for some co-design principles that kind of give us a bit of a framework for how the process typically goes. So the first step, of course, is to establish and maintain meaningful relationships with patients and healthcare staff. Then identify some goals of what the improvement should look like or how to go about doing it. What we'll focus on today is really that explore phase where we're learning about and understanding experiences to identify things that can be improved and researched, and then also developing those ideas and thinking through, okay, what can we do to respond to those gaps that we identify. And then deciding and changing. So selecting an idea for improvement and then implementing it and finally evaluating it to learn. So it's a very similar sort of process as the learning health system that I just showed you, but with a very strong emphasis on learning from folks' experiences. Now I'll pass it over to Danny.
Thanks, Shelley. All right, this is one of my favorite examples that just demonstrates a few different ways that we can engage patient and caregiver partners. And there's sort of one clear winner for highest quality engagement. And this example was originated by the amazing Francine Buchanan, who was nice enough to allow us to use this example for today. So when we ask, what do you want for dinner? There's a few different ways that we can engage to figure out what to make for dinner. So one example is somebody could ask, what do you want for dinner? And really expect the other person to decide. So they don't really want to contribute. They just want the other person to do everything, all the decision-making work and the calibrating work of like, what do we have in the fridge? One person does that. Another way we can ask, what do you want for dinner, is one person might ask, what do you want for dinner? But really they want pizza. And so they're really trying to get you to agree to and say that you too want pizza. So you might say, what do you want for dinner? Pizza, and do a little bit of convincing. And then there's another way we can ask, what do you want for dinner? And it might be two people coming to the table asking each other, what do you want for dinner? And together collaborating to understand, what do we have in the fridge? How tired are we? Who likes to do what task? Who does not have any interest in the chopping versus the sauteing? And who has the capacity to clean? Can we do this together? Or maybe should we just order takeout? And if we do order takeout, we're deciding together what we get and where we get it from. So of course, this isn't a trick. The third one is the highest quality of collaboration. We're really looking for like two people coming to the table, openly, honestly discussing capacity and really working together instead of deciding what's for dinner on projects. Next slide. And this is another graphic, again, from Francine, and she said that she got it from Maureen Smith, who originated this example, but it really shows why we need to collaborate with patient and caregiver partners. So we can see on the left that there are, two loving parents. They just want to do something really nice for their baby and give a beautiful mogul of animals. And we can see from the baby's perspective, it's just a bunch of butts. And so this is like a really great way to show that, researchers and clinicians, maybe they're implementing an intervention or a program, and they can have the best intentions and, have a general idea of what's needed. But it's really important to bring in patient and caregiver perspectives because they're the individuals who are living the system. And they may have perspective unavailable to researchers and clinicians to understand how those initiatives, those interventions, those programs might be perceived and experienced. Next slide. So there are two different branches of co-design that we just wanted to spend a little bit of time differentiating. So we can co-design projects together with patient caregiver partners. That's one way. Another way is that we can use co-design methods to carry out research. So the first method, which is co-designing projects together with patient and caregiver partners, shares leadership. It shares power with patient caregiver partners. So this might look like sustained collaboration over multiple projects, over multiple research projects, and involve some shared decision making. So this could involve patient caregivers partners being involved right from the get-go. So deciding where is there an overlap in research and community need, developing some of those questions together, developing how all parties think it would be best to approach this research, et cetera, et cetera. Then when it comes to actually carrying out the research, we can engage in co-design methods. Those co-design methods may have been thought up together collaboratively with partners, but the partners themselves may not carry out the methods. So co-design methods, there's many different types, and we will get into some of that as we go along in this small lecture portion. But that would be more like patients and caregivers coming to the research as participants, not necessarily as partners, with the goal of sharing their experiences and still contributing their perspectives. But there wouldn't be as much of that shared decision-making, and there would definitely be more limited collaboration there. And again, we will get into more concrete examples of co-design methods in particular, and also of what it looks like to be engaged as a partner. Okay, I'll pass it on.
Thanks, Danny. So in terms of the co-design process or levels of involvement, we call them degrees of co-design. And that can look like a sort of simple process or a degree which is informing or learning, where you're visiting a community hub or a platform just to learn about the available services. And then we sort of increase that intensity with a consultation. Perhaps there's a conversation about certain topics or subject matters or complex problems, and you're consulting to collect feedback, understand stakeholder information and insight and perspectives. And then we move from participant into a partnership, where you're involving the caregiver or patient partner in certain conversations to really understand the problem that you're trying to solve and how they can help to contribute to that solution or various solutions. And then you collaborate, where that's more of a working partnership, and you participate in a variety of workshops, conversations. They could be in person, they could be virtual with multiple stakeholders and partners, where you determine where to focus and how to achieve goals and objectives. And with that comes empowerment. So you're making decisions together so that you're serving as a community ambassador, as someone who's had lived experience, and you're connecting patients, providers, researchers, everyone all together. And to sort of give you a bit of an example of that as a caregiver and participant in research, I was presented with surveys, focus groups and panels. Perhaps it was an email to a link where I fill out the survey or the Q&A just on my own time. And there's often less dialogue or less engagement with a researcher, where they're just seeking my insights and my experience about being a caregiver and as a patient partner, lived experience of my dad, for example. There's very little contact or engagement or follow-up even sometimes with a researcher, and perhaps it may be during, it may be virtual or a phone call. Whereas moving into the partnership type of experience, there was a lot of dialogue and conversation about what the problem was, and they're trying to develop a solution for it. So in this case, I've just put a quick link in the chat. This was something that I was fortunate enough to participate as a partner with, which was a document called All About Me for the Toronto Geriatric Program. And they were trying to develop a tangible resource and solution to making the patient's voice heard, enhance communication, and acknowledge the needs of the person who is accessing help. And so there was a lot of conversation and dialogue and back and forth, where ideas were invited in and we ended up collaborating. They very much empowered me to help them create this document. And in the end, the resource was a very practical solution to a complex problem that they had seen in their environment. Next slide, please. So in the chat, we'd love to hear about your ideas of co-design in terms of, have you used co-design tools or strategies in the past? What do you plan to use co-design for? We'd love to hear your feedback and perhaps your experience of where you've used that. So feel free to use the chat and type in your experiences there, or even some ideas that might be percolating in the past or even now as we're talking about it. Next slide, please. So in terms of participant and partner, the one of the most important aspects of that is building relationships and building rapport. And I won't go through this slide in verbatim, but a lot of the strategies that worked really well for me to be very much engaged in the process with researchers was that they presented active listening. There was a lot of acknowledgement, eye contact, their body language was very open, and it made me feel safe enough to tell my story and tell my father's story as well. Researchers were curious, and so that really helps to build your empathy muscle and to ask a lot of really insightful questions that gain the trust of the person that you're working with, of the patient, partner, and caregiver, and it just shows that you're interested in their story and their information, and that it's not just transactional. Setting and managing expectations is also really important. Understanding what your goals are and objectives are as a researcher, and really explaining and talking about your why. I think purpose and why is really important. And I found I connected really well to the researchers who were engaged in that conversation and sort of turned their spark on to make me really understand what they wanted to know and learn to help the healthcare system. Next slide, please. Some of my reflections in terms of what worked well and what I would seek to do differently as a participant and partner, but also from a researcher perspective. Things that worked really well was, again, the empathy, the tone of voice, the pace of the conversation and the pace of the speech, intonation, eye contact, body language, all of the things that we really know a lot about, but sometimes when you're in task mode, they can be pushed to the wayside. So those things were really, really important and made me feel safe to share my stories. Flexibility in schedule and making appointments. Caregivers and patient partners, especially if they are working, have their hands full. And so presenting them with a variety of different options, a variety of different methods of how to participate and how to partner really go a long way and make them feel validated and acknowledge that their role as a caregiver and patient partner is important, as well as the research and helping to contribute to solutions as well. And I'll go back to understanding the researcher's why and your purpose. Why are you invested in this? Why are you researching this? Why is this important to you? And how does this play into your purpose? Building that emotional connection and resonating emotionally with the caregiver and patient partner really does go a long way. And I found those were the experiences that really helped me to open up to the researcher and contribute and participate. Doing a couple of things differently very quickly would be the lack of flexibility and not understanding my situation. Not asking how my day was or how that moment was. A caregiver's day, patient partner's day can be filled with complexities and emotional turbulence sometimes. So, really just understanding where they are for that moment and where their headspace is before you open up the conversation. Build time for rapport and relationship, and then refraining from robotic sort of Q&A, paper shuffling, always looking down. Let them know that you're taking notes. So if your head goes down for a moment, that's why, or you're doing it on the computer or writing it manually. So those are just some reflections and perspective from the caregiver and patient partner point of view. And next slide, and I'll hand it back over to you.
Thanks so much, Bethany. So just to wrap up this first chunk of the workshop, just kind of speaking to the more relational side of co-design. So in addition to the considerations of how you'll do it and why and to what goals you'll achieve, it's really important to think about the accessibility of your engagements with folks, as well as making it as inclusive as possible. So things that you'll want to consider in terms of removing barriers and just really making the environment comfortable and welcoming for everyone. First, if you're engaging people in person, remember to think about physical barriers that might be in their way and how they might get to your meeting. Think about if you're engaging people virtually, think about accessing technology as well as the internet to have a high enough speed connection to join a virtual meeting, as well as the knowledge and the skills to be able to use something like Zoom or Microsoft Teams. I know it's a daily struggle for most of us when there's links and all those fun roadblocks that you kind of have to go through. So really just thinking through all of that and providing support wherever possible. Then, of course, the time, day, and location. So while 2 p.m. on a Tuesday might work great for you, most people are actually working their regular job. So thinking about evenings or weekends, or in terms of location, going to someone's community yourself rather than asking them to come to you. The last thing about sort of logistics is respite care. So if you are engaging caregivers of young children or older adults or anyone really, be sure to think about whether respite care would be needed so that that person can really fulsomely participate and not be distracted or concerned about their loved one. Then in terms of sort of interpersonal dynamics, we know that, patients and healthcare providers and researchers in their relationships, power manifests differently. So you can use different strategies such as using first names only, or just taking some time at the beginning of every meeting to kind of level set, ask people, what did you do on the weekend, or kind of get to know one another on a more human level, just to kind of bring some of those power imbalances down a little bit if you can. And further to that point, be really careful when you think about the language and the jargon that you're using. So explain any acronyms, give people materials in advance that they can review so that they really do feel equipped to come to the conversation and not worried about, oh, am I going to know what they're talking about? Or if they get lost, then maybe that's kind of like something that might set them back a little bit in terms of how comfortable they feel participating. And then finally, be sure to compensate partners for their time whenever possible. So just really acknowledging that their lived experience and expertise is as valuable as everyone else at the table who presumably is being paid a salary to be there. And there's lots of guidance available online about how much you should be paying people and how that should work. Okay, so now we're going to flip to some examples of co-design methods. And I do just want to call out, we're sharing 2 different examples with you today. And those are the ones that we'll be trying out in our breakout groups. This is not an exhaustive list too, of all of the different methods that you can use. So there's lots of other different ways that you can engage patients. Bhavni showed a good range of examples on the slide that had sort of the table with the rainbow bar going across the bottom, showing different sort of levels of intensity or degrees of engagement. But just for the sake of time and for this workshop, we're just going to dig into 2. I'll pass it back over to Danny.
Thanks, Shelley. So personas. I personally love this method and use it often. A persona is a fictional character based on community demographics and typical patients or providers. So for personas, I always like to say, like, think your classic 2008 like Facebook profile type thing. Like, you have some basic information you can find out about a person in a profile format. So it's often created from existing data sets based on real people or collective ideas of people with lived experience. So the persona itself is not a real person, it's a hypothetical person, but that person is based on information gathered from real people. And so that information can be gathered from quantitative data sets, and there are a whole bunch that can be used depending on the particular topic you might be investigating with the use of personas. But if quantitative data isn't available, or perhaps just you might be on a team that doesn't have quantitative expertise or capacity, you might start to develop some existing data from collective ideas by running focus groups with people with lived experience. And so these personas help us to explore and better understand experiences, needs, assets, and the type of support that all kinds of individuals might need. Next slide. So this is an example of what a persona might look like. I won't read the whole story, but it's just to give you an example. This gives information about, a name, age, location, that they're in a new country, some information on income, caregiving status, food security, mental health, housing. We have all kinds of information in here. And again, depending on your topic and what your data set looked like, or if you're going based on focus group data, you might have very different information in the persona that you might be using. Next slide. So we develop personas, again, either based on quantitative data or based on focus group data, and then often taking those in further focus groups to often co-design those personas to get a more nuanced and in-depth understanding of what that persona might experience. And once that persona is developed, their characteristics and needs can start to help shape how new care processes or interventions are co-designed by thinking through some of the challenges that they might face. So we might ask questions when we're further developing these personas to understand these challenges, like, what's challenging for this persona about the way care is currently offered? What's the most difficult aspect for the persona? How often does that challenge happen? How serious is it when it happens? And what are the consequences or long-term effects? Next slide. And once we start thinking through those challenges and getting a better understanding about, what they are and what they look like in particular contexts for this one persona, we can start to develop ideas for solution-oriented action. This is definitely an emancipatory approach where, like, we might be looking to change things. And often in my experience with personas, like, that might be a care package, for example, that the persona may benefit from using. So to explore these solution-oriented actions, we can start to think about, is the solution or new model of care the same or different across groups of people? How would the solution help to improve challenges for the persona? Who are the important people for the persona to be able to connect with to use the solution or new model of care? we might want to also think about how different groups of people might experience and perceived any solution-oriented action that we may design for the persona itself. Next one. Okay.
All right. Thank you, Danny. Okay, so the second method that we're just going to quickly showcase is called journey mapping. And so with journey maps, they're used to provide a visualization or an illustration of the barriers, facilitators, experiences, and interactions that patients, caregivers, and providers have across a given sort of care journey, it's called. So this could be something like leading up to getting a surgery, or starting from, developing some symptoms and then going through testing and finally getting a diagnosis. So when we do journey mapping, we try to break it up into stages or different sort of steps or key moments that can have pain points, they can have good experiences, they can have, circles where people are going back and forth between two different providers, but they really are meant to sort of break the journey up into all the different steps that patient might have taken. And then once this process is mapped out, then it can be used to show where frustration or where difficulty or gaps exist. And then with that information, then plan new healthcare services that better support patients, fill in gaps in communication, support efficiency and more streamlined care, and are connected to other resources in the community that maybe weren't tapped into or available in the experience that was captured. And so across these different phases of a journey, there are some sort of example questions shown on this slide that you can ask to sort of pull out the details of how did that stage feel? What interactions did you have? What made it difficult? What made it good, maybe? And what can we learn and what can we improve upon? And overall, the goal is to improve access to timely, high quality, and well integrated care. So I know this is very busy and the text is quite small. The thing that I want you to take away from this example of a journey map is just how there are very many twists and turns often. And many of you, I'm sure, can relate to this process, maybe in your own experience or care for a loved one. But this one is about maternity care for someone who does not have a family doctor. So of course, it kind of starts out with searching for a family doctor, then, having a series of conversations that you can see with these speech bubbles. And there's kind of some cyclical action happening here where there's referrals and then they're sent to a different practitioner every time. They have a second pregnancy. And the process kind of continues even beyond with this what's next and sort of ongoing maternity care. But the idea is to really capture some of the chaos, some of the bright points, and also some of the difficulties that a person goes through, and really kind of be able to build upon that and respond. So with that, we're now going to switch to breakout groups. There will be a facilitator in each of your breakout groups, and in those groups, you'll go through two different exercises, first focusing on personas, and then second focusing on journey maps. I hope you all brought your most creative brains today, because there will be a lot of sort of making up stories and pulling on sort of fictional narratives, but hopefully you get a lot out of them. And then once we are finished with the breakout groups, we'll join back here and just have a quick discussion to reflect and chat about any questions that you might have. Okay, so with that, I think we will break out. Welcome back, everyone. So glad that you hung on to this point in the workshop. I know it's a long one and it's summer, but we'll get you back into the sunshine, maybe for a little quick walk around the block very soon. Thank you. I know in my group, I had such a wonderful group of people that really contributed wholeheartedly to the exercises. So thank you so much. It sounds like similar things were happening in other breakout rooms. We have shared the slides with you in the chat and the breakout room document, so you can feel free to refer back to anything that we've shared so far in future. And so now I will share my screen again. So now we just have a really informal couple minutes left for overall discussion, reflection. I am sharing some questions that you can consider here. You can write your response in the chat if you like. You can raise your hand and just speak to how you're thinking and feeling. But yeah, you don't need to report back on anything specific that happened in your group, but I'd love if anyone wants to share their response to any one of these questions, or you can ask your own. Did anyone find it particularly challenging to really come up with the sort of fictional narrative and make up all the details as you were going along?
Shelley, maybe I can respond to this.
Yeah, thanks,
I
Tova.
had a fair bit of consideration going in because I hadn't worked with personas before. And one of the things that I was concerned about was entrenching stereotypes, right? Like, because there are things that are more common in certain communities, but it's not everyone in every community. It just felt like it could be a little bit of a tricky situation. And I was really appreciative. Shelley was my group leader, and she led us very sensitively through the different aspects of this. And what felt like came out of it to me was a very rich and deep picture of a person rather than a flat stereotype of this person. And so that kind of allayed some of my fears and made me feel like one of the really important things with these personas is to like really build out multiple aspects. And so I thought the workshop was really helpful for that, to kind of counter that issue.
Thanks so much. And yeah, I think our group was fortunate to sort of have a bit of a glimpse from one perspective who, had shared similar experiences with the persona. And that was really helpful to kind of give us an idea of how it works in real life and how kind of like real narratives and real experiences can weave into, not creating something that's stereotypical, to your point, Tova, but yeah, really kind of providing a fulsome picture and thinking about a lot of considerations that's like, oh yeah, that person might not have a bus pass, or they might not know how to look at the bus schedule. They might not have money in their pocket, even if they make it to the pharmacy. So really kind of thinking through like each of those steps. And that's really the point of co-design, is to kind of like not just gloss over, like I know I was even guilty in our group of just saying, oh yeah, so he goes to the pharmacy, but it's like, well, wait a second, how? And then what will he do once he gets there? So really important just to kind of like break it down into little itsy bitsy steps, and then you can really identify some of those gaps that people experience. Anyone else want to share?
Had a really amazing question in our group at the end. We didn't have time to address that. I feel like others might be itching for as well, which is, what do we do with these? So
Great.
if anyone else was interested, and I can speak to just very briefly. Always very important at the start of any co-design research project like this, to make sure that the team is engaging actors who can do something about it. So individuals in policy positions, individuals who run organizations, these are very emancipatory projects. So for example, in a project that we just ran, which was focusing only on co-designing personas and related care packages, we partnered with a local Ontario health team who was looking to revamp their program design, and they actually used our personas to help inform their design. We also partnered with a local organization that provided services for the target population, which was older adults, and they actually designed their day programs around our findings from the personas and care packages. So just to give a little bit of a concrete hands-on example.
That's excellent. Thanks so much, Danny. Yeah, yeah. Personas can be used again and again, and especially when they represent a certain community or a certain patient population. You know, you don't always need to go back to the drawing board. They can be really versatile and informative in lots of different contexts. Marianne, I see your hand is raised.
Yes, thanks. So I wanted a bit of clarity on the persona, and I got that, but I saw the persona, the development of the persona on two different levels. First, on the level of the patients you're engaging with, the patients and caregivers you're engaging with to do co-design. You know, I think that sometimes we have you know, an idea or a stereotypical idea of what the patient partner would be, person would be, and how they would interact in the project and so on. So I think you know, there's a persona there that we have to look at ourselves and say, what am I expecting? What is this persona for me in this project? You know, what do I see as being needed? And also then we're talking about the persona we create in order to get us going in the project, in the problem we want to solve. I think though there's a big risk and a big challenge associated with, and it could be good for reflection, associated with what are my stereotypes and what are my biases in dealing with patient partners, or dealing or looking at the persona in terms of trying to create a method to solve the problem. Okay, I think it's important to, in as much as you can, you know, you can use the persona as a tool, but in as much as you can, to now compare that with real life, to compare it with the person you're actually dealing with, and find out from them the same questions you would be using to build a persona, just to see how much it matches and what are the differences and what you're not seeing. I hope I've made myself clear on the personas and how we can use them and what the risks could be.
Yeah, no, that's such a great point. Thank you for sharing that. And I think the one thing that comes to mind is, so we've shared the breakout room document with you all, and on the final page, most groups probably did not get the chance to get to the reflection questions, but the idea is, in an ideal world in real life, you would then not only gather people's experiences based on, you know, or to contribute to a persona or to a journey map, but then you would also then, once you've done either or both of those exercises, then you would still sit down with the patients or whoever, and then reflect and say, okay, so what can we do with this, and what's next, and how are we going to then respond and co-design for looking ahead. And I think that can be a really good way to sort of member check and to make sure that what you've captured is correct, and then what you're thinking about going forward will actually cater to people's needs and the gaps that they've experienced. That doesn't always happen. You don't always get the chance to sit down with patient partners to go to that sort of response step. There's certain situations where maybe it's a research study and you're only doing the journey mapping as sort of a data collection tool, but in the true spirit of genuine co-design, you would then go to that next level with the partners that you have. I think I saw a question in the chat. Does anyone else have any other comments or things that they want to say? I know I've done a lot of talking.
I might chime in here really quickly.
Oh yeah,
sorry.
Please. Yeah.
Yeah, no, I just I found myself thinking along the same lines as Marianne, and to build on what you had mentioned, I think it also kind of highlights the importance of considering commonalities as well as the differences among individuals who we're engaging with when we're trying to design something, since we want it to work for more than just one person, and different people find themselves in different circumstances. I think it speaks to the importance of assessing commonalities as well as the differences, and seeing how those map to each other.
Yeah, that's such a good point. And I wonder, I don't know if folks have had experiences with, you know, developing either personas or journey maps, or even just having similar conversations, maybe not even using those two methods. But when you have a small group of patient partners, it can be such a powerful thing to kind of have a way to make sense of those commonalities and to kind of link people together with their shared experiences, even though obviously everyone is so different in the way that they have, different healthcare needs and experiences and interactions. But yeah, that can be a really powerful sort of byproduct of doing these exercises. So I like that. The one comment or question in the chat, so Shu Feng asked about using AI with some of these exercises. And it's such a great question because what I had told the facilitators in advance, if things are going a little sideways in your breakout groups, you can always just go to ChatGPT and kind of ask it to do some of these exercises for you, and then you could just reflect on it just instead. And of course, that's no substitute for people's real lived experiences. But personally, I have found that even just asking ChatGPT, like, hey, can you make a patient vignette about someone who's, an older adult, they've fractured their hip, they don't know how to make sense of their x-ray that their doctor has shared with them, and they're feeling confused and frustrated and just kind of spun out. And it actually did a pretty good job of creating this patient story, conveying emotion and kind of getting to the needs that that person has. So I would encourage you all to, if you are working on a project where you might not have the opportunity to work with patient partners, or you just kind of want a little flavor of something, or even if you are working with patient partners and you want something to sort of kick off that conversation, yeah, AI can be a good tool to look to, at least to consider. Kath?
Yeah, I was just thinking about this very interesting conversation because there's a sort of tension between specification and generalizability. And then I also think there's a risk of these exercises kind of pushing us to keep designing for 80% of the population. And ideally, from an equity lens, if we could actually design for the most marginalized, it would likely work well for everyone, right? Curb cuts work for all sorts of people. So
Yeah.
I don't know. I just think to keep that in mind, that if we have to make choices, we should be thinking about the most vulnerable, the most marginalized, and thinking through that experience. From that perspective, we could potentially come to some design choices that are good for lots of folks.
Absolutely. Such a good point. Okay, I'm just looking at the time. We just have a few more slides. There's some resources developed by some of my colleagues at the Institute for Better Health. You can access them using this QR code, and they're all about co-design. It was a sort of an educational series that walks through personas, journey maps. Some of our materials that we shared with you today were based on what's available at this link. And then there's some additional information there and worksheets and things like that. So I really encourage you to check that out if you're interested by what we've been discussing today. And just in the final moment, we do have an evaluation survey. It would be amazing if you could just take 2 minutes to let us know what you thought about today's workshop, and what we can continue to offer in the future to support your embedded research and your professional development. We'd love to hear your feedback so that we can respond. So thank you once again, everyone, for coming. The slides and the breakout room document have been shared in the chat. If anyone wants to stay on and ask any further questions, you're more than welcome to do so. But it's 1:30 where I am. So thanks again, and have a great rest of your day.